and thank you for ISOT 2025 for giving me this opportunity to give a talk on post-operative surgical complication in ABO incompatible transplant. Excuse me. Okay. So kidney transplant is optimal care for the end-stage renal disease patient, considering the shortage of the organ donor and increasing number of the patients with end-stage renal disease, the extending the extended waiting time for the potential renal allograft recipient. About one-third of the potential living donor are blood group incompatible. To expanding the living donor pool beyond the immunological barrier, like ABO incompatible transplantation, is getting increasingly popular all over the world. The process involved desensitization from 1 to 4 weeks prior to the transplantation and increased immunosuppression, at least for first 2 weeks. The complication rate is higher as compared to the normal compatible kidney transplant patient. The complication is more in early post-operative period rather than the long term, and the major complication involves the infection, ABMR, bleeding, and so this is a national database study from US reported in 2013. There is a comparison for ABO incompatible as well as the compatible patients. There is a significant increase in the hemorrhage, wound infection, and pneumonia. The preoperative complication, if we divide the complications, surgical complication, preoperative complication is the first. The majority of the center uses the combinations of triple immunosuppression, including prednisolone, mycophenolate, and tacrolimus 1 to 2 weeks before the transplantation. Plasmapheresis is used to remove anti-blood group antibodies. There is increased chance of infection related to the lines. So no, there is no data of preoperative infection and complication of the transplant, as the transplantation get postponed if there is infection. Now we come to intraoperative and postoperative complication. Bleeding is the main cause for the complication which we are dealing with. There is an increase. It increases due to the depletion of clotting factors, including the fibrinogen by plasmapheresis. Albumin, as a replacement fluid, produces more clotting disturbance with replacement of FFP. Splenectomies give the 4 times more risk, but it is virtually given up by most of the institution. The plasma exchange can reduce the fibrinogen by 60% in a single session of plasmapheresis. So this is the data which shows 0 to 90 degrees day of the transplantation. There is more risk of wound infection, UTI, sepsis, and hemorrhage in the ABO incompatible in initial phase of 0 to 90 days as compared to 91 to 365 days. There are further few studies from the different countries which shows the ABO incompatible kidney transplant have more risk of blood loss. And in a study where in the Netherlands, which shows some of the patients require erythrocyte transfusion in 48 hours. Platelet count decreases 28% on an average and return to normal in 1 week after the transplant. There is a study in Germany which shows the pediatric patient which shows three patient underwent ABO incompatible kidney transplant using immunoabsorption. One required repeated blood transfusion, another patient required surgical intervention. In contrast to low bleeding complications in Japan is seen because they are accepting they are giving the less number of plasmapheresis and accepting the cutoff titer as compared to Indian subcontinent. How we can prevent the bleeding? If we restrict the plasma exchange, number of plasma exchange, as in the Japan, they accept more number, higher titer, 1:64. Now they are going to 256 as well. The replacement with the clotting factor and fibrinogen after plasma exchange, and use of FFP as a replacement fluid instead of albumin, they reduces the chances of bleeding during intraoperative and postoperative. And we can replace heparin with naftromostat. It is a protease inhibitor with a short half-life, and it can be removed with dialysis. Next complication is the infection. The US national data suggests there is wound infection more in ABO incompatible patient, 12.5% as compared to 7.3%. Pneumonia and UTI in the first 90 days. The further few of the studies also shows there is higher chances of infection in the ABO incompatible as compared to the compatible patients. So how we can prevent the bleeding? If we restrict the number of plasma exchange by accepting the high titer of anti-A and anti-B antibodies, like some of the Japanese centers are doing, and a replacement of the clotting factor and fibrinogen after plasma exchange. And if we use FFP for the replacement fluid. Next is the wound infection. It is more likely in ABO incompatible patient due to the excessive bleeding either during the surgery or post-operative period, where they require this retain collection, which can lead into the infection, post-operative infection. Other risk factors also include the high BMI, diabetes, and early age, which cause wound infection more as compared to the normal patient. 3.5 times relatively risk of wound infection is seen in even after 91 days in some of the patients. And sirolimus-based immunosuppression has twice the risk of compared to those patients with discharge with trachylimus and the MFF. UTI and is the another high uh, chances of UTI in ABO incompatible patients as compared to the compatible patients. In the first 90 days, it has been seen as 24.5% higher risk as compared to the compatible patient. The increased risk is due to the rituximab, the duration and the type of pre-transplant immunosuppression and post-transplant immunosuppression. Plasmapheresis increases the risk due to the hypoimmunoglobulin. In a single plasma exchange, IgG can reduce up to 40 to 60%. Pneumonia is the only one life-threatening complication which is seen in early post-operative period. 7.6% more risk as compared to the ABO incompatible. Other infection like viral infection, BK virus, CMV virus have higher risk as compared to immunocompatible patients. Other complications are also been seen in lymphocytes, complication related to rituximab. According to Professor Dr. Tanabe, neutropenia has been seen with the rituximab treatment patient, and it can be relieved after the surgery as well. Strategy to reduce: we reduce the dose of rituximab to 200 microgram, and early reduction of the dose of mycophenolate after 2 to 3 weeks of the transplantation. Limit the number of plasma exchange to 3 to 5, and long-term prophylaxis with cotrimoxazole and the vancomycin. Acute rejection and TBD cell-mediated rejection is leading cause of the graft failure in ABO incompatible transplant. ABMR is seen in 17 to 30% more as compared to ABO incompatible compatible patient. So in our hospital, NH-Artex, we have done a study where with our Dr. Deepak Shankar Ray, we have done a study in August 2015 to 2018. We did the data and collected the data post-transplant from September 2019 to 2021. So we have made our recommended protocol in which we have tailor-made the protocol, and we target the anti-A titer less than 1.8, 1:8 in initial first year, but we raised it to the 1:32. Now subsequently we have raised it to 1:65. Initially prednisolone will start to 50 milligrams and maintain at 7.5, but now we have reduced to 20 milligrams and maintain it for 5 milligrams. The baseline anti-AB titer was initially 1:32. With if the patient is having a titer of 1:32, 1 or no plasma exchange is required. If the patient is having the titer of 1:8, we straight away go with the transplantation with the rituximab 100 milligram. And though no prophylactic plasmapheresis is given post-transplantation. B-cell depletion, initial in 2013 to 14, we gave the rituximab as 500 microgram per day. Then we reduced it to 200 from now 2016. We are giving in the titer less than or equal to 256, 100 milligram, and more than 512, we give 200. conventional plasmapheresis is given low volume exchange 30 milligram ml per kg, and replacement fluid is with the FFP. Induction, we all know, induction we give the ATG 3 milligram per kg body weight in 2 divided dose 0 to 1. Methylprednisolone 500 milligram, 2 doses 0 and 1 day, 0 and day 1. Maintenance, traclomeres, mycophenolate and prednisolone. We do the follow-up and give the TAC level of 10 to 12 in first 3 months, and reduces to 8 to 10 after 3 months, and 6 to 8 in the next 6 months. Prednisolone, we start with the 20 milligram and continue till 1 month, and taper it to 2.5 milligram per month till the maintenance dose of 5. And antiviral prophylaxis, we give vancomycin for 90 days and co-tramadol once a day for 6 months. These are some of the data means comparison. The duration, average duration is 20 days if you include the pre-transplant plasmapheresis, and the discharge creatinine was 1.5. And follow-up, sequential follow-up 0, 4, 8, 12, 6, and 20 months is compared to serum creatinine is comparable. The infection, pneumonia, UTI, they all are as comparably acceptable as compared to ABOI compatible transplant group. Rejection is almost same. The graft survival and death is more than 90%. Conclusion, there is no significant difference in the midterm outcome like patient survival, graft survival, graft function, incidence of infection and rejection over the period of 3 to 6 years on ABOI incompatible patients. ABOI incompatible donor can help to expand the donor pool for maintaining the organ shortage of the transplantation. ABOI incompetent transplantation with plasmapheresis plus single dose of rituximab and low dose of IgG with standard triple immunosuppression can be performed to excel the result. Only there is slight increase in the cost of the transplantation as compared to the compatible. No additional infrastructure is required, and we can expand the pool with 30 to 35%. Thank you.